Well, thank you very much indeed for the invitation and for the introduction, Matthew. I'm delighted to be here and tell you a little bit about how we got into this work, what we've been doing, and what we're planning to do next. So I'm a consultant microbiologist at the Queen Elizabeth Hospital, and I also work with something called the Surgical Reconstruction and Microbiology Research Center, which is a center based between the University Hospitals Birmingham and the university, and particularly looks into research into trauma, and we have a big part of it with research into infections related to trauma. And I also do need to acknowledge so much of the work of Fenella Halstead, who really should be standing up here and giving this talk. So our theme, part of it had been looking at alternative treatments for wound infection, understanding that we have big problems with antimicrobial resistance, and we had started to develop platforms or models to assess biofilm formation and how antimicrobials might work against it in vitro. There's obviously a big clinical need because there are large numbers of patients with chronic infections who need a lot of antimicrobials, and we clearly have a big problem with the lack of systemic antibiotics, at least. And we came to hear about Sergi Hani-RO and understood that there was at least some evidence on individual cases of good efficacy. But we felt that before moving on to definitive clinical trials, you needed to look at how the product works in the test tube, and then move on to smaller scale trials to have proof of concept, and then perhaps go into the big things. And we were also aware that there was in vitro evidence of activity for important comparator honeys, such as Medi honey and Manuka honey, where research had also been already been done on biofilms. So if we just go backwards a step and ask what biofilms are and why we think they're so important, and why we believe at least that if you're looking at a product that is going to work against the kinds of infections where biofilms are involved, we really do need to at least do some in vitro testing. So this is a definition: a structured consortium of microbial cells surrounded by a self-produced polymer matrix. So wherever bacteria encounter a surface, be it plastic or metal or a surface in the human or animal body, their tendency is to stick onto it and form a biofilm. A small number of cells stick on first, they aggregate, and they form this matrix, and they're stuck on there. But of course, bacteria fall off of this, and they're able to carry on disseminating and causing infection. Are biofilms important? They're everywhere. They suggest that in the human body, about 60% of infections actually involve a biofilm. And you can just see there we have really all the device-related infections you can think about, ventriculus, neurosurgical, contact lenses. I think you've already been hearing about lungs, peripheral vascular catheters, urinary catheters, but then human tissue as well, with all sorts of chronic infections, and we've been particularly, obviously, interested in wounds because of our links with trauma. So mostly chronic infections are actually associated with a biofilm. And we know a few things. We know that they're actually harder to treat because they're much more resistant to antibiotics when they're in this state where they're living stuck onto a surface, slowing down their metabolism and protected from the effect of antibiotics. We know there are lots of treatment failures, particularly with systemic antibiotics, which are going to find it so hard to penetrate to the site. They're also much harder to diagnose because it's difficult to recover the bugs from a clinical sample, and when we do, we don't even know that we've got all of them. The other thing is we're all in the laboratory very clear about spend a lot of time deciding exactly how we're going to do our antimicrobial susceptibility testing and what it means. But of course, in the laboratory, we don't test the bacteria in the biofilm state. We test them in the planktonic state. And there are all sorts of breakpoints that tell us whether an antibiotic is likely to work or not. For biofilms, we don't have any breakpoints. And this just reminds us that there's such a significant burden of infection, delayed wound healing. There's been a lot of controversy about just how important the bacteria that live in a wound are. Microbiologists have tended to suggest that they're just colonizing and causing little damage, but we think now there's a body of evidence suggesting they do delay wound healing, they do damage grafts in burn wounds, and they can go on to cause systemic infection. As I say, systemic antibiotics may not work at all. Of course, there is a big market of antimicrobial dressings. They don't always work. They seem to be expensive. And the literature about their genuine efficacy is rather scanty. So we've been looking at alternative topical agents. We've been particularly interested in acetic acid, but there are lots of other natural products that seem to us to be there for a purpose and likely to work, and we were very interested in looking at Sergi Honey RO. And the two types of experiment we like to do is to see if the product prevents biofilm forming and also to see what it does to an existing biofilm. And as I said, we have models for both of these. If I describe how we assess the prevention of biofilm formation, we get the organism in a broth, then put it in these microtiter plates, add the diluted product that we're testing, and then after a while we're able to wash the plate and see if there's still bacteria in a biofilm there through an assay. So that's a very neat little experiment, and we're delighted that we've just had a publication in the Journal of Wound Care looking at Sergi Honey versus a range of other products in this model. So just to run by the results and exactly what we did, we measured this minimum inhibition concentration on a panel of 16 organisms that we have firstly got from wound infections and think are important in wound infections. Things like Pseudomonas aeruginosa, Acinetobacter, Staph aureus, and a range of multi-drug resistant organisms where you might think a new novel agent might find it challenging to be effective. And we tested a range of honeys and other antimicrobial dressings. And in summary, Sergi Honey RO prevented biofilm formation for all 16 isolates. It was generally more potent than the other honeys that we tested. SH1 effective at lower dilutions, equivalent in 5, the only effective honey in 1 of only 2 effective honeys in 2, and we do see some different results in some cases. So this is just an example of the sort of result we get with a particular Pseudomonas aeruginosa isolate. And here you can see Sergi Honey diluted 1 in 3 and 1 in 6 having a big effect compared to the positive control. With the competitor honeys really not having anywhere near that sort of effect, really quite minimal. Here you have an E. coli, which perhaps is a little easier for antimicrobials to kill, and we have equivalence across the different honeys. And here we look at a range of other dressings, Aquacel, Actylite, and variety of things. And again, we see a very good effect with Sergi Honey, and some of the antimicrobial dressings very little. And we have actually published on this as well. The other way we can look at whether a product works is to test whether it actually acts against a biofilm once it's already there. Here we create a biofilm on a peg, and then we see if the product can actually kill it and prevent it from being able to seed. And here we do have some results again. And again, we see seeding reduced at reasonable concentrations, 1 in 3 and 1 in 6 of Sergi honey for 14 of those same 16 isolates. So of course, this work isn't tell you everything. There are some limitations. Of course, it's in vitro. We're looking at what happens to a biofilm on plastic, and that can't ever mimic what happens on tissue. Many researchers do have various tissue models as well, and we may go on to look at those in the future. Of course, we've taken just one organism at a time. We are looking now at combinations, but this certainly isn't exactly how things would work in a chronic wound. And of course, we can't assess anything like toxicity or wound healing from our model. So we felt that the next step that was feasible and practical for us was to move on to at least get an idea about how this works in the clinical setting. And I'll be very interested afterwards to hear what people think, because it is very, very difficult to do comparative trials where every single patient's wound is quite different, their risk factors are different, how they're living their lives is different. So our proposal, and we're just in the process of finalizing ethical approval and starting on the study because we now have the funding, is that we would use the same patient as their own control. And we are planning to use patients with bilateral chronic venous ulcers. We're going to do this very much as feasibility, proof of principle study, in as much to find out if this sort of clinical trial works for assessing the efficacy of various agents on chronic wounds. So the patients will need to have bilateral venous leg ulcers that have failed on standard of care for at least 6 weeks, so they're not going anywhere. Many of the patients we're actually going to test have had these ulcers for years rather than just a few weeks. They act as their own control, and they'll be in the study for 6 weeks, having twice weekly dressing changes. And we're going to look at 2 endpoints. Firstly, the time to the ulcer healing, and we're going to do this in a very standardized and reproducible way using a 3-dimensional camera known as the Icona camera, but we're also going to have a microbiological endpoint where we look at the changes in the bacterial burden on the wounds themselves. So that's the plan. Patient 18 years or older with these chronic bilateral ulcers will go to be into the study, and then each leg will be randomized as to whether the left or the right leg gets which agent. One leg will get Sergi honey, and the other the standard of care that we use at the moment. So that would be really what they've been failing on. As I say, we're about to start. We believe that we'll get 15 patients through the study very, very quickly because this clinic is very busy, and we hope that the findings of that will allow us to then go ideally to NIHR to get grant funding for a bigger study. So in summary, Sergi honey RO is effective at both preventing and eradicating biofilms from in vitro. Largely, we've seen superior activity compared to other honeys and other antimicrobial dressings. We think it is potentially an exciting option for chronic wounds, and we're about to look at that and hopefully be able to report back soon. So I just want to acknowledge all the people who've been so helpful in going so far and also in helping us plan and prepare for the clinical trial. Thank you very much.